Hello, and welcome to the first Coding Insights webinar of 2016, presented by Health Forum and the American Hospital Association. I'm Chabre Ross, and I will be your moderator for today. Today, our topic is ICD-10 with a new lens, how medical coding can affect everything from safety reporting to population health matters. Research on this topic is presented today by Dr. Andrew Boyd. We have a disclaimer that we like to provide for you to look at on your screens. This is just telling you that the topics of today's presentation and the views are those of the speaker and are not necessarily those reflected by the American Hospital Association. Again, I will be your moderator, and our speaker will be Andrew Boyd. For some housekeeping instructions, you can see at the bottom of your screen you have a Materials tab and Ask a Question tab. So if you would like to locate the materials for the CEUs, please click the Materials tab, and if you have a question, please click Ask a Question. Our learning objectives for today are quality measurement, public health, health policy planning, and clinical research, and how ICD-10 affects these within the hospital. As another disclaimer, this presentation is not about the proper coding rules to assign a code, but the challenges that are faced in running into these issues in the hospital for ICD-9 and ICD-10. Without further ado, I will turn over the presentation to Dr. Boyd.
Hello. Thank you so much, American Hospital Association and Health Forum, for giving me this opportunity. Talking about the transition to ICD-10 is an exciting area, and hopefully we have some interesting questions and we provide a little bit different perspective on hopefully running reports and getting to the bottom of the information. One of the first slides that I start out with when talking about ICD-10 and ICD-10 is sort of the experience worldwide from the peer-reviewed literature. So the World Health Organization's version of ICD-10, not the clinical modification version that we're all using today to assign diagnosis codes for proper billing, that was only 14,000 codes when it came out in the early 90s. So ICD-9-CM is approximately the same size as the World Health Organization's version. Because we came up with ICD-10-CM a little bit later than the rest of the countries, and started deploying it, we do have some experience from other countries with their versions of ICD-10. Switzerland came up with their own version, and after about 5 years of experience with their version of ICD-10, they improved the sensitivity from about 37% to 45%. So hopefully with the appropriate training and engagement of professional coders and physicians, it won't take the U.S. 5 years to improve the quality, but that was at least experience in one area. So another country that had deployed ICD-10-CM, or ICD-10-CA, my correction, was Canada. They had previously been using ICD-9-CM with appropriate licenses, but they switched to the CA version because CM had not been released. During their peer-reviewed literature, 7 of the diagnosis categories actually had worse sensitivity in ICD-10-CA. So even though we have additional granularity and additional definitions, the transformation from ICD-9 to ICD-10, no matter what version of country version, you do have some challenges. Now, many of you may or may not be familiar with that all public health agencies had transitioned to the World Health Organization's version of ICD-10 many years ago. And so one of the peer review articles looking at that transition from a public health reporting challenge showed that there was a 20% increase in septicemia as well as a 60% decrease in bronchitis. Now, we didn't have a huge change in the patient population, but from this experience, as you change definition, the reports, the information that you gather do change, and not all the time do the reports match up perfect one-to-one. And this is just to help provide some context and some framing. These are hard challenges, and from other transitions from the world as well as the U.S. public health position, we have challenges. So how do we help? So, U.S. experience with ICD-10 CM. So the good news, the acting chief for Center for Medicaid and Medicare Services stated at the end of October only 10% of claims were denied, and 0.09% were denied because of invalid ICD-10 CM codes. So good news, most people are still getting paid on a regular basis. Some road bumps have come up. There are published reports between 30 to 40% decrease in productivity of professional coders 1 month in. Hopefully, as Switzerland had a similar problem with learning curve, we can decrease the amount of times. There have been a little bit of projected concerns. CMS, one of the problems was the fact that in peer review simulation, even after a year of ICD-10, it still took 50% longer. And the last problem, which if you're in California, Louisiana, Maryland, or Montana, your Medicaid bills are actually approved using algorithms in ICD-9 CM. So they're actually submitting codes in ICD-10, mapping back to ICD-9 because they were not yet ready for ICD-10. So again, we have not heard any reports of denied claims, but these are some experiences with ICD-10, and let's see how we can try to improve the transition. So we all transitioned October 1st, as you all know. The AMA projected for individual clinics between 83,000 to 2.7 million. Hospital-wide data of how much it would cost individual hospitals has been not as reported nearly as much as individual clinic-based. As you all know, Congress delayed CMS. Congress told CMS to delay ICD-10 CM for 1 year. The estimates are literally on cost of billions and billions of dollars. So even the 1 year delay. So what this chart to the right is the AMA analysis of how hard it was for mapping from 9 to 10. So going from 10 back to 9, you can see a 1-to-1 approximate match with one choice was 82%, and with an exact match, 5%. So for 87% of the 10 codes going back to 9, the transition should be easy. And this was done by the American Medical Association, so they were discouraging the transition to ICD-10. So you would think this would be as hard as it could be. When you look forward, you have 49% going to 10 with one choice, and about 24% with an exact match. Again, 75% going forward of 1-to-1 exact matches with only one choice. Based on this report and multiple other reports, running reports or analysis across the transition from October 1st forward or October 1st backward should be easy. However, and looking in one direction, either just backwards or just forwards, have actually been proposed by one researcher and peer-reviewed and many other researchers and many different companies. So, perfect disclaimer. GEMS, the general equivalent mappings, is not a resubstitute for appropriately coding a native ICD-10 CM. This file is designed to help us run reports, help us make decisions, help us understand the data as we make this transition forward. In 20 years, we'll be used to ICD-10, but we do have 30 years of data in ICD-9 CM. So if you just look forward with the general equivalent mapping files, you only map forward to 16,000 ICD-10 codes. When you're mapping forward, 76% of the ICD-10 codes never get used. When I've talked to individuals on the data analyst side or different companies, and when we mention this, they say, oh, good, we'll just map backwards to the older data. We know the reports. We have 30 years of experience. However, if you use the GEM mapping just straight backwards, you do cover all the ICD-10 CM codes, but you only map back to 11,603 ICD-9 CM codes. 34% of historical data has no mapping back to. So, when you're trying to run reports with just a simple GEMS file forward or backwards, or even commercial systems forward or backwards, you don't have complete coverage. Now, if you're using categories of codes, you may not experience the same level of problems. But if you're actually looking at individual diagnosis codes, your reports aren't going to add up. So, how do we simplify this? How do we take this inherent contradiction from the government of missing 30% of historical data or 70% of new data? So what we did was we took the original GEM files, we visualized a joint network, we analyzed the motifs, we simplified it, and then we looked at the individual discriminatory by clinical subspecialty. So, if you've all looked at the general equivalent mapping files, it is literally a text file with the ICD-9 code, the ICD-10 code, and the flag. For this presentation, for most of this research, we've ignored the flag. That's another level of dimension that complicates the overall mapping. If you're trying to do exact maps or trying to understand studies, the flags are important. But if you're trying to process 100,000 codes and simplify it, that was a level we were unable to get to. But the actual labels, ICD-9, ICD-10, and flag, we added those. But it is literally a text file with a 9 and a 10 code. So how do you take this and try to simplify this? So what we did was we considered every diagnosis code as a circle, sort of like a hub or a city on a map. And then if it mapped one direction, we gave it an arrow to the 10 code. So scrotal varices maps backwards to scrotal varices. Good news, in ICD-10, scrotal varices also maps back to scrotal varices. So from a network point of view, what we're trying to do is transition the text file that the government gave us into something that A, we can run algorithms off of, and B, help people understand why the reports don't always add up. So bipolar affective disorder, mixed and moderate degree. So from an analytical point of view, if it's just forward and back, you just replace the codes. But they're not all that easy. So the networks do increase in complexity. So we have a 5-fold increase in the number of codes. So one of the network motifs is disturbances of salivary secretion. Go forward to K11.7, disturbances of salivary secretion. We've also added more information or a new diagnosis, dry mouth unspecified. But if you're running reports about salivary problems, you just swap out these two codes for the one code in reports for analysts. So they're not all that easy. So here's an example of the increased complexity where you have 3 specific ICD-9 codes that map forward to the same ICD-10 code, but they don't all map back equally. So this one is 653.90. It's non-reciprocal. So depending on what direction you're going in, you may not be able to map back. So again, depending on what the question is and how you're running individual reports, this may or may not be a problem. So why is running reports so hard? This is an overall view of what ICD-9 to ICD-10 looks like at the high level. If you zoom in to 6,400%, you can read the individual ICD-9 and ICD-10 codes. The top left corner is type 1 and type 2 diabetes with all of the descriptions of medication and treatments and complications. So, although we're all learning the new ICD-10 codes and we're all trying to do our best, this figure shows why running reports is hard. Running reports isn't from that point of view. The good news is we were able to take this perspective and simplify it further so you can run reports or at least understand where to go next. So our simplification method, what you can do is take a look. You're not trying to do a report on all 14,000 ICD-9 codes or on all 80,000 ICD-10 codes at the same time. So what we did was we looked at the individual relationship between the 9 and the 10 codes, sort of like that initial report showed with the 75% and the 85% simple one-to-one match. But we want to look at both directions at the same time. So what we did, if you look at the left side of the axes, the first column is one-to-one, many-to-one, one-to-many, and none. And then you also look in the other direction, from 10 back to 9, one-to-one, many-to-one, one-to-many, and none. So the top left corner, going forward and backwards, is the example we gave you of scrotal varices. If you look at the overall code in forward and backwards, there is nothing else affiliated with that. Running reports on one-to-one forward and one-to-one backwards is just replacing the codes. Now, what does it mean to have one-to-one going forward and many-to-one going backwards? Well, if you look at the light blue next, a perfect example of that is ear infection. An ICD-9 CM, all you could say is they have ear infection. An ICD-10 CM, you have right ear, left ear, bilateral ear, as well as unspecified. So forward and backward easy mapping is all related to unspecified, but the additional information of those secondary ICD-10 codes make an easy report. You can still study how many ear infections you have. You just swap out one code for multiple codes. If you map over one further, so one-to-one forward and one-to-many going back, the yellow, that concept is sort of like depression. So we have a couple of different depression diagnoses. One family medicine happened to use a lot. Hospitals not so much, was 311, which was symptoms of depression, not the DSM-4, DSM-5 diagnosis of depression. Well, a single depressive episode and 311 are merged together in the same code in ICD-10. The depressive symptoms doesn't exist. So when you're running reports, they all collapse down to a single ICD-10 code. So across the top, we have easy backwards and forwards, light blue, which is class to subclass, and yellow, which where you're losing data. All of the pink area are areas where running reports for one reason or another are very, very hard. So we talk about primary, which is the code of interest, and secondary codes. The secondary codes, when they point to other codes, they make a large web-like network, sort of a cobweb. And so when you have secondary codes pointing to multiple things, either from the 9 perspective or the 10 perspective, being able to run reports, you need to ask questions. And so we've used the relationship networks that are revealed by the large complex diagram and provide them to you. So what happens, and so we can walk down many to one, one to many, and also none. So none going forward, you can actually have ICD-10 codes mapping back to 9 codes that do not map forward. In the bottom right corner, none to none, there are ICD-9 and ICD-10 codes that don't map to anything. So what does this overall diagram lead you when you synthesize it together? So we've come up with 5 classes for ICD-9 codes. When you want to run a report and you want to know how hard or easy it is, you want to know how many are identity. Well, the good news is 28% of ICD-9 codes are or 28, are replaced by a single ICD-10 code. Malignant neoplasm of the penis is still malignant neoplasm of the penis. So, great. However, when you go to class to subclass, when you're actually increasing the information, 22% of those old ICD-9 CM codes map forward to more information in an easy way. So if your report is focused on one of those codes, all you have to do, for example, like folate deficiency anemia, you can sit there and actually just replace the one code with 4 or 5 codes, or even 1,000 codes, or a few hundred codes, depending on the overall network. As I mentioned before, for 12% of the ICD-9 codes, we actually lose information. So with a 5-fold increase in the number of codes, it's surprising that 12% of ICD-9 codes lose information, but they do. And so, for example, 296.20, depressive psychosis unspecified, major depressive disorder. A lot of primary care docs did not like to use the 296. They used 311. That is no longer around, so for an official diagnosis of depression is F32.9. So, however, as we saw previously, we had those large complex networks where they get forward and backwards, and so we called those types of codes convoluted. So, labeling them convoluted is our way of saying, listen, the mappings forward and backwards are complex. You need to talk to the clinician, to the people who are asking for the report, to say, why are you trying to do it? It may not be possible to run the same type of report, or the numbers may not just add up. But again, from the mathematical relationship pointing forward and backwards, you can understand and appreciate, as well as no mapping. 1% of the codes actually have no mapping forward. So overall, the top part of the figure of the nice, pretty constellations is convoluted. The next area tends to be more the class to subclass, where you have more data in ICD-10, but it's relatively easy to replace. The bottom portion of the graph was identity, and then there's a little line here of individual codes. So, what does this all mean? So, if you would like, I've just spent about 10-15 minutes on the methodology. We have 3 peer-reviewed journal articles going through and having multiple words documenting and explaining the methodology. So, I have not gone through everything, but if you want, here are the 3 journal articles published in the Journal of American Medical Informatics Association that describe the mapping forward, the mapping back, and the challenges for the patient safety indicators. So each of these have been peer-reviewed. We've had a number of different journal articles and other journals as well peer-reviewed. The methodology is solid. We have given away all of the SQL code for the concepts of convolution. If you have your own mappings, please feel free to reach out and use the codes. So this is a simplification method. We said 36% of the ICD-9 CM codes are convoluted. With all the secondary codes, we only looked if they pointed to the primary ICD-10 code. For the secondary code that we mentioned, we never looked if anything else was pointing to it. So one example of a very complex code, E929.2, is a convoluted code, but when you're probing 909.0, it's actually a class to subclass. So we're only representing a single ICD-9 code, not the overall full network. And so when you actually look for all the complications, for the concept of entanglement where things are really tied up into a big web, the true number is 42%. So from our simplification method, yes, I know it sounds bizarre, the big network diagram being a simplification method, but we represent 36% of the complication, and so we're missing 6% of the overall connectedness of the ICD-9 to ICD-10. That's represented by the entanglement concept, but again, if you're only probing the primary code, you will be good using this methodology. If you care about all the codes, again, these networks tend to propagate and expand to hundreds of codes. So, this is all well and good. However, not all codes are used equally. Abdominal pain, if anyone who's worked in the emergency room or Seeing hospital discharge, abdominal pain is frequently encountered. I haven't met many professional coders who use EA45.0, accident involving spacecraft injury and occupant of spacecraft. So the previous methodology and the previous analysis assumed every code was used equally. Everyone knows that's not true, and depending on where you are and what type of patient population and what the disease burden is, not all diagnosis codes are treated equally. So, what is the overall impact on the subspecialties? So, ICD-10 has clinical classes or families. And so what we did was we took each individual ICD-9 code within the different ranges and looked to see if it was convoluted, subclass to class, class to subclass, or identity. The good news for oncology and hematology, they were some of the easiest and least complicated mappings between 9 and 10. As you have all heard by multiple training seminars, pregnancy and childbirth is some of the most complex transitions to ICD-10-CM. So we showed that 60% of the ICD-9-CM codes are convoluted. Again, we're not actually evaluating the content of the definition change. We're evaluating the relationships with the ICD-10 codes. And you can see where this additional information can actually give you insight. As you're trying to run reports, by looking at how complex they are, you can spend more time or allocate more resources. So when you look at this, even the hematologist oncologists, when I presented it to them, they were like, great. However, when you look at infectious and parasitic disease, which all hospitals and doctors and clinics deal with infection and parasitic disease, that's 40% convoluted. However, although we've had an increase in the number of codes, one of the interesting quirks of ICD-10, we actually lose 20% of our codes describing infectious and parasitic diseases. So, although we've continued to evolve and we've added lots more codes, especially to the injuring and poisoning, where there's a 15-fold increase, there's information within the relationships. And how do we use this information? So, this whole time we've talked about going from 9 to 10. We're crossing a bridge. And when you're looking forward, things look relatively rosy. However, once we're in 10, if you're trying to map backwards to 9, even looking at both ways, the percentages change. So, for example, the identity 4,123 diagnosis codes is the same, but your denominator just got a whole lot bigger. So, what used to be 24% is now 5.9%. And looking backwards, the vast majority, when trying to run reports, initiating in 10, running back to 9, 81% of the mappings are convoluted. So, and again, about 1% have no mapping backwards either. So, if you look at, this is the clinical classes for ICD-10-CM. Again, hematology seems to be the least convoluted. Again, external causes of morbidity is very convoluted, and which is not surprising, seeing the 14-fold increase in the number of codes. Childbirth, again, is still complex. Neoplasms, for oncology, does tend to increase in complexity a little bit more. So, again, depending on if you're in 9 looking forward to 10, or 10 looking forward back to 9, how complicated your report is going to be be affected. I'm not saying everyone should map forward or back. It really depends on what you're trying to answer and what type of question you're trying to propose. So, we took a look at the patient safety indicators, and we took a look at the 27 patient safety indicators, and 23 of them use ICD-9-CM code. And you look at, and then we took an analysis and took all the ICD-9 codes that are used for reporting the patient safety indicators and actually mapped to see how complex. Were they convoluted? Were they simple? Were there no mappings? And then we did a mapping to see if we could understand what the potential impact coding was if you're trying to run it. And then we also looked at the comparison to the published ICD-10 CM data sets. So, for the patient safety analysis, there were 4 different data sets we used. One was the 23 PSI metrics. This is all published on the Agency for Health Research Quality. The categorization or the methodology that we just walked through, we use that as well. We also used an Illinois Medicaid data set, so about 38,000 patients, and we also used the ICD-10 CM codes and the actual new definitions from the website, from the Agency for Health Research Quality website. So just looking at the overall complexity, there are some patient safety indicators that have simple mapping to ICD-10. PSI 6, PSI 8, and PSI 17, the ICD-9 to ICD-10 codes are self-contained. They don't contain codes that map with other codes. You should be able to run reports and get almost identical answers. You shouldn't have a way to increase numbers accidentally. PSI code with no mapping, many times within the PSI, there will be diagnosis codes that are 4 digits or 3 digits, which are legal codes that you can get reimbursed to. But all 3 and 4 digit codes were not mapped by the government, by the general equivalent files. So when there is actually no mapping provided by the government and they're part of the PSI, that's what the no mapping means. And then when you look all the way down at the bottom, the most complex is the rate of complications for anesthesia. 25% of those codes in the numerator don't map forward, and the rest of them are really, really complex. So, the way you calculate PSI is you just take the codes from the hospital and you run them. You don't map your old codes forward or your new codes backwards. But when the numbers don't add up, or all of a sudden you become a whole lot safer than you used to be, or you become a whole lot worse, you want to try to start to understand why are the numbers so different. And so when we looked at many of the complications and we looked at the mappings, we did a mapping forward and back. This is not how you calculate them, but what we're trying to understand with the under and over reporting is the codes mean different things and they have relationship to other codes. And so this is trying to show how the concepts have become entangled, intertwined, and so the reports aren't going to be identical. And we're trying to explain why and allow the patient safety officers to actually dig deeper in. So, for example, some of the ones with no mapping. So, as I said before, there are official 3- and 4-digit codes that are approved by CMS. However, not all of those 4-digit codes or 3-digit codes were mapped by the general equivalent mappings. Why they didn't do that, you can ask CMS. But because of that, PSI 3, 7, 12, and 22 don't really measure the same thing. So EXP1, the rate of complication, has actually been discontinued in ICD-10. So, for the patient safety reporting. So, when you actually look at some of the complications of foreign body during procedures, you can actually show that the complexity, there are 219 codes related to foreign body. And so the mapping forward and the concepts related to foreign bodies are now so complex that they didn't try to map forward and backwards. So you have to say whether it's adhesions, obstruction. So mapping forward and back doesn't really make sense. And for accidental puncture, There are now 98 codes related to puncture and lesions capturing where the injured organ was. So the overall mapping forward and back for PSI 15 and 25, it does not make sense, and so the GEMS file didn't map it. But when you're actually running the reports, that increased detail may or may not be properly encoded in ICD-10, which could cause changes in patient safety reporting. So we took this concept of convoluted individual codes that are well entangled, sort of like a spider web. And so EXP1, as we said before, has been discontinued in ICD-10. One of the weaknesses of the method is we treat all codes equally. So the post-operative sepsis rate maps into its network the concept of sepsis, which causes the convolution, which is not part of the post-operative sepsis rate calculation. And so that's why it was complex. The post-operative hematoma and hemorrhage, that, again, is a huge challenge because you have to focus on organ system. And so all of this additional information, when trying to map forward and backwards, or trying to run reports or understand why the reports aren't adding up, even though they call the report the same thing, this is some of the reasons why. And this was revealed quickly and seamlessly by the concept of convolution and simplification. So post-operative respiratory failure, and again, these are codes that they have the concept of respiratory failure in that overall network, but they're not part of the PSI. So we're not saying you're going to have reporting problems with it, but as those concepts have changed, it's sort of like a tree. They've taken a few branches off, reassembled the branches in new areas. Things don't always add up. And through looking at the overall network, you can begin to look at things. So one of the interesting side notes about PSI, especially for the complications of foreign body, is what the new detail is. So, in ICD-9 CM, you had acute reaction to foreign substance. You come in multiple visits, you get recorded. If you have a foreign body accidentally left in during a visit, all of these report against your PSI. However, in ICD-10 CM, you have the concept of A and D, initial encounter and subsequent encounter. The subsequent encounter is not included as part of the PSI calculation. So, if the purpose of the visit is to diagnose and treat the adhesion of foreign body, you're supposed to use initial encounter. If you use subsequent encounter, it doesn't count against you. So, if coders or doctors or hospitals accidentally use D and your patient safety indicators start looking better, people actually have to go back and dig in to say, hey, wait a second, we're not this safe. And so the actual appropriate coding, again, we have 80,000 codes. You need to make sure initial encounter, if the purpose of the visit is the foreign body, that you use A, initial encounter. So inappropriate use of D could make you look safer. And again, this is a subtlety, and there are pressures, and you have lots of times, and you're only spending a few minutes per code, and you're adding lots of codes. These are the key things where you need to code appropriately. But management and everyone else needs to also understand that, hey, even if you look good, you need to dig deeper. So, moving on. Case study 2. We took an Illinois Medicaid data set. We had 38,644 patients with 1.4 million patient encounters, $382 million in payments. So almost 300 institutions included. So is this representative of the whole country? No, it's representative of Illinois. But it at least gives you an idea of how complex some of this is, as well as how we could go forward. So this isn't just the coding schemes at University of Illinois, it's multiple institutions. Although it's not perfectly representative, it's a decent sample. So, and everything was actually billed via ICD-9 CM code, no DRGs, nothing like that. Good news! news. 24% of the visits and 30% of the cost were identity. You can run identical maps, identical reports. So, however, one of the challenges were 2% of the visits and 2% of the cost have no mapping. Not critical, but it's still 2%. However, a quarter of your visits and 22% of your cost are convoluted. I'm not saying you can't run reports. You just have to spend time and drill down to why the reports are convoluted, especially if there's gender information, or especially if you're using these convoluted codes for individual diagnosis, or trying to order supplies, or trying to manage staff. So these codes get used for lots and lots of things. So convolution and planning. So why does convolution matter? So sickle cell disease with mention of crisis 282.64 is only for 0.3% of the encounters. However, sickle cell disease is a high cost. 1% of all the cost is covered by this one diagnosis code. So why do we care? And why is convoluted critical? So 282.64, if you put in most commercial systems and most EHRs, it will map forward to D57.219, sickle cell disease with crisis unspecified. If you put in D57.219 into most commercial EHR systems, they will map backwards to 282.64. And you're wanting to open up a new sickle cell clinic. So you run a report on your old 30-year data, and you're like, hey, we've got 100 sickle cell patients a month. This is interesting. Let's go forward. Let's run it in ICD-10. All of a sudden, you run it with D57.219. Instead of 100 patients a month, you're only at 80. 20 of your patients have disappeared. So when you look, what we reveal to you is 282.64 is convoluted because you have two ICD-10 codes pointing to the 9 code in a relationship. Most commercial EHR systems, if you go to D57.211 or D57.212, they will tell you they map back to 282.64. But at 282.64, they don't actually tell you that they map back to. So if you're trying to decide if you want to open a sickle cell clinic, the fact that you have D57.211 and D57.212, you want them all mapped back and categorized together to say how many sickle cell patients you have. You run the report, and you're like, ooh, 100, now we have 100 again. So the report's the same. However, if you're asking a surgeon about splenic excretion, you can't map all the codes back to 282.64. For some reports, you have to map it to splenic excretion. Or if you're talking to a pulmonologist, D57.211 should map back to acute chest syndrome. So depending on who is interpreting the report and why they're interpreting the report will determine what code or how you affiliate them. And when we label a code as convoluted, we're not telling you what the decision is. What we're telling you is you need to spend more time or talk to the people. Or take a look at it and say, you know what, this is too complicated. The reports will never be the same. We're just going forward. One of my collaborators, in using the tools that we've developed, and the links are at the end, has said when they put in the individual codes for reports, it's called the bug splat methodology. If it looks like a bug just got squished, they move on and don't spend the time actually running the reports. He likes the concept of convoluted, but he likes the bug splat analogy too. So that's not an official analogy, and there's no science, but if it really looks like a bug, then you're in trouble. So what are some of the limitations of simple mapping? One of the codes that is frequently encountered, at least in Illinois, hopefully it's not as encountered across the country, is 250.02, type 2 diabetes mellitus, unspecified, uncontrolled, without mention of complications. There is no ICD-10 code mapping back to this. Patients can live with type 2 diabetes for a number of years without complications, and they may not be on medicine or they may not want to take medicine. So if you're only looking backwards, you can miss historical data, especially like very large codes that are used frequently. So mapping forward and back at the same time is really hard. We've tried to simplify it or at least highlight where the really hard parts are, but if you only look in one direction without a little bit of thought, you're going to miss a lot of historical data. So, looking forward, our third case study is pediatrics. We took a look at the pediatrics, and it's just waiting, sorry. We took a look at the pediatric cases. Since this was an Illinois Medicaid data set, we decided to go forward and just individually identify the ICD-10 codes that are used by pediatricians. So we had 174,500 patient encounters with pediatricians. Chandra, my computer is frozen. Is it frozen on the display as well, or everything good to go?
We're on slide 38, correct?
You should be on slide 38.
Okay, so, I pushed it through.
Okay, all right. For some reason, mine is not updating, so I'll just tell you to advance the slides, okay?
Okay.
So we're on case study 3, pediatrics. And basically what we did was we looked at the pediatricians used a total of 2,700 diagnosis codes, about $12 million in total payments. This is Medicaid payments, so if you're looking at other insurers, it's probably going to be a larger number of payments. So the good news for pediatricians, 33% were identity, and only 26% were convoluted. However, if you go to the next slide, the slide titled Pediatric Percentages, so when you look at no mapping compared to the overall statewide database, you're actually at 0.5% no mapping. And when you look at the percent for practicing pediatricians, what percentage are convoluted or having a hard time running reports, you actually have 20.7% of the patient visits and 16% of the reimbursement. So a little bit easier than the overall. However, what we did was, because convoluted can help highlight where some of the hard problems are and where some of the frequently used codes are, we as collaborators got 4 practicing pediatricians to take a look at the individual diagnosis codes and looked at the mapping forward. And so if you switch to the next slide, the top of it should read, quality of mapping could affect results. So when looking at the individual mappings, there are times when there's actually information loss, overlapping categories, and inconsistent. So one of the examples, since this is a group of hospital coders, 401.0, malignant essential hypertension, is actually mapped forward to essential primary hypertension. When they transformed ICD-10, the concept of malignant essential hypertension does not exist anymore. One of the challenges was it was actually used to have a hospital qualifying admission diagnosis, but it is a distinct topic. So when you're running reports, whether or not essential primary hypertension counts towards a hospital admission, because the information is lost, this is the type of analysis you need to do, at least from your perspective, to make sure even simple mapping sometimes going forward. There are some times and again, this is just from a pediatric point of view for practicing pediatricians. As a hospital, you might have a different perspective. Cardiologists have different perspective. Insurance companies have different perspectives. But this was just from the perspective of a practicing pediatrician and the type of descriptiveness they actually want to describe. So, overlapping categories. Again, sort of a non-inflammatory disorder of the vulva also maps to a vulval cyst. So the mappings don't always intuitive from a clinical point of view. And so what this shows is when you're using the mapping for reports, even though we review they're convoluted or we review that they are simple, having domain experts actually look at the reports before you make unrecoverable decisions are appropriate. And then again, some of them are slightly inconsistent. V32.00, it's twin single live birth. That's the primary purpose of the diagnosis. But if you just take the GEMS file without any analysis, that actually maps forward to Z3830, twin live birth infant delivered vaginally. And so when you're doing these reports, you need to be careful about what you're mapping because you don't want more kids or less kids than you actually are delivered when you're trying to run the reports. So this is an example, and if you go to the pediatrics article, you can sit there and look at which ones we labeled from a pediatric point of view, some challenges or disagreements, but you must take these mappings cautiously. So if next slide. So the slide should read discussion. So specific diagnoses and diseases will have difficult time running codes. If it's a convoluted code, you're going to have to talk to who's asking for the report. Just like the sickle cell mapping, you need to be careful of who's asking. If it's a surgeon, it might be different than if it's someone trying to set up a sickle cell clinic, which is different than if it was a pulmonologist. Training of personnel and management should focus on the frequently used and complex motif. So we're talking about if you're using these reports often and you need a 1, 2, or 3 year running average, then you're going to have to figure these things out. Because we have 30 years of data, it would be a shame to lose all of that. We do provide all of these tools for free. If all of you who are currently on the website, on the webinar, all hit the websites in the next 5 minutes, you'll crash your server, but please feel free to use the tool rest of the afternoon or at any time that's convenient for you. The mapping motifs, the SQL code, the Excel file, how we've categorized everything we've done for this is given for free. So if you have a commercial system with their own mappings instead of the GEMS file, if you have access to them, you can run the same types of analysis on commercially provided systems. One of the reasons we have not done commercially provided systems is we don't have the copyright to their systems, and that's their proprietary trade secrets. So this analysis is very easily to replicate, and we have given away all of our code and all of our methodologies for free. And we've even provided, just like the example of the sickle cell, on the websites, if you put in your list of 25 codes or 2 codes, you can get a visual map, you can get a text file, and you can get an online table as well, if you would prefer that. So again, what our job was trying to not tell you how to code appropriately, but when you're running the reports, what exactly happens and which ones are convoluted. So it doesn't solve all of your problems. So we're switching to the next slide, take-home points. So all of this is assuming that we have accurately coded data. You can't make healthcare decisions. You can't report patient safety indicators. You can't make decisions about hiring new staff or who the appropriate staff is without appropriate coded data. So although it took Switzerland 5 years to ramp up to the same quality, you should take most coded data, at least for a few months as we're learning, with a little bit of a grain of salt. But you need to do the best you can with the tools and the training you have. If you have questions, ask. As we've shown from the U.S. transition, it is taking people a little bit longer, but again, this is a new system. We're asking people to go from 14,000 codes to 80,000 codes. We're beyond human comprehension for some of these diseases or some of the types of coding specification. ICD-10 translations, again, we're not saying that you're going to calculate patient safety indicators wrong. No, patient safety indicators are defined by Agency for Health Research Quality, and you run them off the numbers. However, as a patient safety officer or as a hospital, If all of a sudden you're 20% safer or 20% less safe or worse, you actually want to understand why these coding schemes are actually going on, or what's behind the numbers. Is it just a change in definition? And what we're trying to do is help give you reasons or help appreciate why some of these codes might be happening that way. Responsible organizations need to make sure when you are mapping between or running reports, if you're using the report for the same reason, you have to make sure the mappings are consistent across your organization. Otherwise, everyone's going to get different answers. And during this transition period, you really do. You also have to be proactive. You really have to train people in the appropriate way to code. Otherwise, you may inadvertently look more safe or less safe. So if you go to the next slide, which is collaborators. I'm the one giving the presentation today, but I've had a huge team of collaborators on a number of different projects. I have a number of collaborators from the University of Arizona, as well as from the University of Illinois at Chicago. As you see, many of them have worked on different projects. Many of them have been repeated. I'm in debt to all of them. If you have specific questions that are beyond what I can answer, I'll be happy to refer to many of them as well. If you go to the next slide. For funding, this was funded by the NIH, the UIC, and University of Illinois and the Department of Biomedical and Health Information Sciences. And then if you go to the last slide, questions. You have my email address. Feel free to ask me emails. Again, this was a collaboration between University of Illinois at Chicago, the hospital system, as well as Yves Lucier, Girong, and many others at the University of Arizona too, who I'm forever indebted to. This is a team-based project, just as we're all trying to get through ICD-10 together nationwide to come up with solutions. We actually needed to have a very impressive team who I'm indebted to. So the last page of the slide is all the wonderful citations if you want to pull up the individual articles, and I'll open this up to questions. And Chandra, I apologize, my computer is still frozen, so I'll need you to read the questions.
No problem, Dr. Boyd. Thank you so much for giving your time today, and I'd like to inform everybody that this was volunteer time given to us by Dr. Boyd, so we appreciate it very much. The slide that's currently up is the survey. Please complete this survey so that you can get your CEU verification forms. And now I will read some of the questions that we received during our webinar today. So the first question we have is from Joseph Nichols. It says, how much of the changes we are seeing are related to clinical documentation improvement efforts rather than the code change?
Well, because the individual codes require more information, if a physician is not actually assigning the codes, education to the physicians needed to occur. So it's not just increased clinical documentation improvement, but when you literally specify within the injury code what bone, whether it's medial or proximal, there is a 5-fold increase in the number of codes. So some of it is improved documentation. Some of it is coders or people or anyone who's working with teams calling the physician to say, hey, you didn't say left versus right. Which one was it? In this educational cycle that's been going on for the last 6 months. So improved documentation helps, but the vocabulary we have now is 80,000 diagnosis codes. You just didn't have that descriptive ability with ICD-9-CM.
Thank you. The next question we have is from Antoinette. It says, for 10% claims denied, are these for inpatient and outpatient altogether?
This was a quote from the director of the acting director of Center for Medicaid Services. Within the individual article, it did not specify what. That when I'm trying to. I believe it was Modern Health. No, it wasn't Modern Healthcare. I don't look in the citations. It was in Healthcare Informatics. where the quote was generated. So that was, I believe, over all submitted claims. It wasn't just outpatient, inpatient. But again, it was the data the government representative decided to present. So.
Okay, the next question we have is from Addis. How do we know that the government agencies, Medicaid, is mapping correctly from ICD-10 to ICD-9?
That is a very good question. They have hired out to appropriate companies a mapping backwards. Their statement said was they started with the mapping from 10 to 9 from provided by Center for Medicaid and Medicare Services, and then they added more information. But they aren't revealing what their complete mapping backwards is. So the way they got around this is through the whole approval and denial method, they actually will maintain the simulated ICD-9 code with the actual submitted ICD-10 code. And the way Medicaid and Medicare signed off on this is they were supposed to have an expedited appeal process. There was a well-documented report in the coding literature when it first happened. I have not heard any reports from the 4 states that are mapping back, as well as the nice thing about Medicaid is they actually have to tell you what they're doing. I've heard rumor and discussions that some of the smaller health insurers are doing the same thing, but when they deny a claim, why they deny a claim is sort of hidden from us. I wish they were more forthcoming so I could do an analysis to see if what they're actually doing, but it's sort of like doing a transformation of an image and you take away 1/3 of the colors. It will never look the same, but they're still using the same older ICD-9 approval algorithms. So I have not heard any reported problems. I'm not saying there is. I'm not saying there isn't. But the U.S. government signed off on it, and if you are experiencing problems, please talk to them, and maybe there's stuff that hasn't been reported yet.
Okay. Our next question is from Denise. Is there a consensus on bridging the report gap between ICD-9 and ICD-10, or is it left up to the individual hospitals and practices to resolve?
It's left up to the individual hospital and practices to resolve. How you handle it, how some people are just ignoring it and going forward. Some people want older data. Some hospitals have actually invested, and they've been dual coding for a year beforehand and are going to dual code for a year afterwards. Some people are hiring commercial companies who will create simulated codes, so they sort of have a simulated dual coding system. Obviously, the whole presentation was about some of the limitations thereof. So how you individually make decisions is up to you. I'm not saying it's easy, and for some, instead of investing time, if you order the same supplies you did last February, for some people that's good enough. Or you try to so it depends on how you're using the data and what type of resources you have.
Okay. Our next question is from Louise. How important is productivity in the initial implementation of ICD-10, and when will the new productivity standards be available?
I don't know. I'll have to get back to you on that. I just have the productivity numbers that have been reported in the press and the productivity numbers that have been reported in the peer-reviewed literature. The scary part from my point of view was the study by, and this was the one, I'm trying to remember what citation it was. It was citation 6. They actually had someone coding an ICD-10 CM for over a year. And even after a year of coding in 10, given the same case a year later, it still took them 50% longer in 10 than 9. we're really, and this is something that is hard to prove definitively, we're really reaching beyond what individuals can remember in their head. I mean, you can't memorize 6,000 codes. When people were assigning ICD-10 codes, you might have a top 10 or 20 you assign routinely, but instead of 10 or 20 codes now, we're talking about hundreds of thousands of codes. So that sort of instantaneous, I know that code off the top of my head, may never come back. But doing this in the systematic, peer-reviewed manner is very, very hard. I think we will find out as we continue to progress along. Hopefully we come to somewhat closer to time neutral. If it doesn't, then it's a permanent increase in cost across the whole U.S. healthcare system. But I don't know the answer to that one.
Okay. Our next question comes from Martina, and I'm going to hope that I read this question correctly. Use of T8519A versus the same with, I'm assuming she means ICD-10. Assume coding is accurate. Per coding guidelines, then this, the correct coding, makes the safety look better, question mark.
So what I wasn't saying that image was per coding guidelines. What that image was to show you that if you inappropriately use D, so to my understanding, go back to your manuals, if the primary purpose of the visit is a foreign body, even if it's a second or third visit, you're supposed to use initial visit. If someone says, ooh, this is the second visit, and inappropriately codes subsequent visit, then you look safer. So, again, that's knowing the training, knowing that this is an area where it's very important for reporting and knowing exactly what the rules are for when it should be initial visit, subsequent visit, or sequelae visit. Coders need to know, and it needs to be watched. Otherwise, you can get drift of definitions between coders and hospitals and along those lines.
All right. Our next question is from Deborah. How would we obtain the SQL code to determine the convoluted?
So if you go to the websites, basically it's a cut and paste. You cut in your codes, and we'll either give you a graph display or a text file. If you actually want the Excel file of all the ICD-9 or all the ICD-10 codes individually labeled, convoluted, simple, subclass, no mapping, on the website that I sent you all to, we also have an Excel file. What the SQL file is for, if you build your own mapping network, because not everyone uses GEMS. Sometimes people build their own mapping network or they use a commercial one. Once you've created that table, what the SQL file does will map each individual code into the appropriate category from that figure, and then you can calculate convolution. So if you have your own mappings, you can use the SQL code to actually find out, is your mapping more or less convoluted? If you're only using the GEM files, we have pre-calculated every ICD-9 code and every ICD-10 code, and it's in a downloadable Excel file at the website. So depending on where you're going or how sophisticated your team is, we've given you everything from an easy website to the individual analysis. So, I mean, every hospital, I'm not saying every hospital created their own mapping, but there are sometimes they go, this isn't right. And if you make changes, then you can help do the analysis there. And it's all released for free. It's not even copyright left. So if you're a for-profit hospital system, you can use it too. It's all derived from the government files. So it's hard to copyright government work.
We have a second question from Joseph. How do you handle mixed granularity? For example, ICD-9 includes open fracture, while ICD-10 includes open fracture type 1, 2, 3A, 3B, or 3C.
I would have to look at the individual code and the relationships with it. The strength of this methodology is we actually don't evaluate the medical information. What we're evaluating is the relationship between all the other codes. And we will provide you from a mathematical point of view where from a mathematical point of view challenges are when you're trying to run reports. Adding in that medical or coding information about exactly where the different types of fractures are, that would literally it took the government years and years and years to come up with the ICD-10 codes, and that is, although we've had a dozen collaborators, that's literally a team of probably over 100 people. So I would have to go pull up that individual code.
Okay. Those are all the questions that I'm going to ask. I've filtered through some other ones that were more related directly to codes, which I don't feel appropriate to answer on this venue. So I'm going to refer back to our slides to remind everybody to please complete the survey. And also, if you have any questions on your regular coding, please don't hesitate to visit www.codingclinicadvisor.com to submit your questions that you may have. And I would like to thank you all again for joining us today. Have a great rest of your week.